Good morning. My name is Adrian Dix. I'm BC's Minister of Health. I'm speaking to you this morning from the territory of the Musqueam, of the Squamish, of the Tsleil-Waututh First Nations. Honored to be here on their lands. I'm joined in Victoria by Dr. Bonnie Henry, who's speaking from the territories of the Lekwungen-speaking people, the Slungis, and the Esquimalt First Nations. This is our COVID-19 briefing for Friday, January the 21st. And with that, it's my honor to introduce Dr. Bonnie Henry.
Thank you very much.
Update. I'm going to begin by sharing a few slides, giving some information that we have been pulling together around people who are in hospital and help us understand who is more likely to end up with severe enough illness that they require hospitalization. We continue to see a decrease and a slowdown in new cases in British Columbia, and as of the last few days, tentatively, a slowing down in hospital admissions. However, they do continue to be high relative to what we have seen throughout this pandemic. So to give you a sense of hospitalization risk based hospital in British Columbia. And this is a measure that we've been trying to understand who is in our hospitals. How has it changed during this period, with Omicron being the predominant strain that we're seeing circulating, and who is at risk? And there's a number of reasons for this. One is so that we can provide that extra advice to people about who needs to be tested, who needs to take extra precautions in the community, but also so that we know that it can guide who has access to the treatments that are becoming available here in BC, including Paxlovid, which we received and will be receiving, as well as Sotrovimab, which is a monoclonal antibody that is used for some people as well. So what we did, and kudos to our analysis team, we looked at 606 people who were hospitalized out of a little over 49,000 confirmed COVID-19 cases between December 14th and January 6th. And we analyzed what were the risk factors underlying people's need for admission to hospital. And during this period of time, the hospitalization rate was in confirmed cases during this period was 1.2%. So that is very similar to what we presented in the modeling presentation a week ago, and it shows that it is a dramatic decrease from what we saw with the Delta wave that we were managing between September and October. So what puts someone at risk, greater risk for COVID-19 hospitalization now? And it should be said, this is similar to what we have seen across the entire pandemic. The single most important risk factor for having severe illness with COVID-19 that requires hospitalization is age. And people who are aged 80 and over are 28 times more likely to be hospitalized if they get infected with COVID-19, controlling for every other risk factor. So this is really, really important. Once again, we know that it is our seniors and elders who are most at risk in the community, in long-term care homes, and across the board. And really, we see that major increase after age 70. We also see an increase in risk of hospitalization for people who have immune-compromising conditions, and we have a few of those on here. If you're a transplant recipient, for example, people who have diabetes, respiratory illness, heart conditions, and as we have found out through the studies that have been led by investigators here in BC, that pregnancy is also a risk for having more severe illness and ending up in hospital. On the positive side, we see across the board, again, that vaccination is highly, highly protective, and it reduces your risk by 9 times if you control for all of these other factors to have your booster dose. And that is, that's encouraging. It reminds us that right now, being vaccinated not only reduces your risk of being infected, though it's not 100% for sure, but when you get that third booster dose, it does increase your risk, or decrease your risk of being infected, but dramatically decreases your risk of needing hospitalization. If we look at, we divide things out by risk categories. Oops. and we look at people who have combinations of risk factors that make them at a very high risk, we see that between the period of September and October and December and January, so comparing what was predominantly Delta to now what's predominantly Omicron, that regardless of the risk category, there's a lower rate of hospitalization right now. So that's important. That tells us that even those at very high risk have a much lower hospitalization rate now than what we were seeing in the fall. And this is a combination of factors, including the fact that most people, especially in the very high risk categories, are vaccinated right now. But also it does reflect that Omicron is causing less severe illness in most people. The challenge, of course, that we have is that Omicron is infecting many more people. So this lower hospitalization rate still translates into large numbers of people requiring hospital care, and we're seeing that impact in our hospitals right now. The other thing that we can look at is putting this together by risk, by age group. So putting how many people in each age category fit into the high, medium, low, or very low risk age groups, and you can risk categories. And as you can see, for people under age 20, the vast majority of that population is a very low risk, with a small proportion at about a low risk and an even smaller proportion with a medium risk. But as we go up in age, the proportion of people in that age category who have those higher risk factors for ending up in hospital goes up. So again, it's another way of looking at who are more likely to end up in hospital, regardless of all the important things that we put in place to, like vaccination, and who needs to take extra precautions, be extra careful about what they're doing in the community, about the measures that they're taking as Omicron is spreading widely right now. So putting all this together, it helps us get what we call a heat map, or a whole a way of looking at our risk based on age, based on our sex, because we know that has implications. We know that since the beginning of this pandemic, men with COVID are more likely to be have more severe illness and be admitted to hospital than women for a variety of reasons. But it also helps us break it down by vaccination. And really, what you can see across the board is once you have 2 doses of vaccine, and particularly as we get older, 3 doses of vaccine are highly protective at keeping people out of hospital. And those people right now who are most at risk, who are most likely to end up in hospital if you get infected with COVID, are people who do not have any vaccines. So a combination of things that we are looking at. This supports the information that we provided through the modeling that was done last week, and it really looks at who is in our hospital, who's at risk of ending up in hospital with this wave that we are all going through right now. And that tells us what are the things that we can do and who do we need to focus on to prevent hospitalizations and severe illness, putting this all together. And so I know this is difficult to see on the screen, but it will be available on the Vccdc website, and I encourage people to have a look. If we look at young people who are vaccinated, and even older people who are vaccinated with 3 doses, your risk of having severe enough illness that you need hospitalization is negligible. It's under 1%. So that's important. That's really good news. And even 2 doses reduces your risk substantially. But if you are even younger, and you don't have vaccine on board, your chances of getting more severe illness go up dramatically, particularly if you have any of the underlying at-risk conditions that make it more likely. So this gives us a sense of what is going on in terms of the people who are ending up in hospital right now. As we know, this is a rapidly evolving situation with Omicron, and I know that when public health guidance changes, the changes raise a lot of questions and concerns. We all ask ourselves, with the new or eased restrictions, what does this mean to me and my family, and what do I need to be doing differently as we move through this new and different wave of the pandemic. So I want to spend a little bit of time talking about this. I have talked about some of the changes we have in testing and isolation, but I think we need to go back to the basic principles. The Omicron variant is different, so we have adapted how we manage this situation. While most people now will not need testing for COVID-19, it is important that we all have the information we need about what measures we can take to prevent spread of illness and to manage when we are exposed or get sick ourselves. Even with Omicron spreading, most people being tested for COVID-19 don't have it. Yes, we have our highest test positivity rates ever, and it's in the 20% to 30% range. But that means that 70% of people with symptoms who are being tested don't have COVID-19. So we need to put that in context as well. This change aligns with the evidence-based communicable disease principles that we follow when we manage in public health, when we're managing any respiratory communicable disease. And from the very beginning, contact tracing is a public health intervention that is well suited and applied to some communicable diseases and not others. Disease characteristics that make contact tracing effective are things like having a longer incubation period, because you have to have time to find people after somebody's been tested. Low infectiousness, as we've seen, as with this with COVID, for example, as it becomes more and more infectious, it's much more challenging to find people with contact tracing. And we also need measures, effective measures that contacts can take to prevent infection for themselves or to others. And if we look at measles, for example, that has a 2 to 3 week incubation period, we have time to find somebody. We can provide them with vaccination, for example, that can protect them from developing symptoms themselves. Other diseases are hepatitis, for example, where again, you can provide an intervention that will prevent transmission. These disease characteristics make it possible to identify and reach a high proportion of contacts who can then take measures to protect themselves or others. And early on in this pandemic, even up until the Delta wave, we were able to find most people in that 5 to 7 day incubation period and have them isolate so that they wouldn't be a risk to others. But we now have a couple of things that have changed. One, this is highly infectious now, and it has a shorter incubation period. And many people will have mild or asymptomatic infections and not even realize that they are infected. And we have new and better interventions, including vaccines and now some treatments. So with the emergence of these more transmissible variants with shorter incubation periods, COVID-19 is no longer an infection for which contact tracing is an effective intervention. We now need to shift our management and think about the things that we can do across the board to prevent transmission and to prevent ourselves from being exposed. The number one most important one, of course, is vaccination. Self-management, so making sure we're managing our own symptoms, and testing of those who are eligible for treatment, and for a testing of people who are living or working in higher risk settings. That's the change that we've been making over this past few weeks as we've learned more and more about Omicron and how it is different from the other strains of COVID that of SARS-CoV-2 that we've seen. I absolutely recognize this as a shift, and it means we have to change our way of thinking that we have been working on so intently together for the last 2 years. But we are all familiar with these new measures. They're much more like how we manage other respiratory illnesses, even influenza or RSV or enteroviruses that cause the common cold. We cannot eliminate all risk. And I think that's something that we need to understand and accept as this virus has changed and has become part of what we will be living with for years to come. But we can use all of the layers of protection to keep our workplaces, our schools, our healthcare, and other activities running as safely as possible. So at this time, everyone, all of us, needs to routinely check ourselves every day, self-monitor. And if we have symptoms that might be COVID, that might be influenza, that might be a cold, we need to stay home till we feel better. And there are some caveats to that, which I'll go through. Right now, with the level of transmission in our communities, we all need to assume that we have been in contact with somebody with the virus. And what does that mean for our daily activities? First, when it comes to what we have been doing, following public health guidance, we need to keep doing that. What that means, getting vaccinated, absolutely. There is incontrovertible evidence, and I've shown you some of it today, that vaccination not only reduces your risk of transmission, doesn't eliminate it, but it reduces it, and it reduces your risk of passing it on to others. But most importantly, it dramatically decreases your risk of having severe enough illness that you end up in hospital. Washing our hands regularly, wearing good quality masks when we're in indoor settings, keeping our groups small because we are still in this wave, and being extra cautious if you're at higher risk. And I've explained some of the things that make people at higher risk. In addition to following the public health guidance, things like having our vaccine card program so that we mitigate those risks, and we provide extra protection for those who are more at risk of having severe illness, which includes people who are not yet protected through vaccination. That's an extra layer of protection. Second, as long as we are feeling well in this new context, we can and must continue going to work, going to school, and socializing safely in our small groups. We are all close contacts of somebody with the virus, so we absolutely need to pay attention to how we are feeling and making sure that we have a very low threshold for staying away and waiting for another day if we're feeling unwell. But we don't need to isolate. If a friend or family member knows that they have COVID, because there are many more people who've not been tested who may have it as well. And we need to treat this across the board as if we've been exposed. So the next question is, what happens if you or a family member starts to feel unwell? The rule of thumb, and what we all need to pay attention to right now, is if you're feeling unwell, stay away from others and return to normal activities when you're feeling better. Particularly if you have a fever, you need to stay home and stay away from others. But if you have a mild illness like a sore throat or the sniffles, stay home. And if you feel better the next day, then you can go back to school or work or childcare. This applies to children in daycare or in school, as well as with adults. We know the COVID-19 transmission is widespread, but there are also other respiratory illnesses that are circulating right now, and these measures apply to them all. So how do you know if you have COVID-19 or need to get tested? A starting point to answer that question is the newly updated Vccdc Symptom Checker. It outlines the symptoms of COVID-19, and it helps let you know if you are in one of those risk categories that should be booking a test. Otherwise, continue to follow that path of staying home until you are feeling better. If the symptom checker advises you to get tested, then you should continue to limit your interactions with others and get tested as soon as possible, and follow the requirements for self-isolation. I'll talk to those in a minute. So these are the requirements for unvaccinated adults. If you test positive for COVID, we know that the risk of having longer-lasting, more severe illness is higher, so you must self-isolate for 10 days. For people who are vaccinated and for children, 5 days is the important period of time if you know you're COVID positive. Of course, with all guidance, there are always exceptions. If you are clinically extremely vulnerable, the conditions that are more likely to make you have more severe illness, if you're immune compromised, such as people going through cancer treatments or other treatments that affect your immune system, or have organ transplants, or you're over age 70, then you are likely to need a test. You should get tested right away so you can access treatment if that is needed. And if you are having any other medical conditions that make it difficulty breathing or have concerns about chest pain, please seek medical attention immediately. So I know we get asked, and I've been asked as I've talked about this a number of times, why is isolation different for unvaccinated adults and children who test positive? So we know that vaccination, and we've seen more and more evidence of this, helps us clear the virus faster. And it's been shown to reduce transmission with Delta and with previous variants. And we have some data now out of Copenhagen that shows that, particularly with the booster dose, but with 2 doses of vaccine, you also reduce transmission in the family. And therefore, vaccination allows for a shorter minimum isolation period. It doesn't mean that it eliminates that risk, and we've seen that. People who have infected with Omicron, even with mild illness, can shed for up to 10 days, like we see with other variants. But that risk is reduced, and it goes down quite dramatically after about day 3 to 5. So we are mitigating that risk. That's why we say it's important to continue to do those other things, like wearing a mask when you're around other people, following the COVID safety plans that you have in your workplace, following the plans that are in place in childcare or in schools. Children are a much lower risk of severe illness, thankfully, and that's one of the bright lights in this pandemic. And there is increasing evidence that the social isolation can impact children's development by limiting their opportunities for interaction with others, and a shorter isolation period enables us to have that other important getting back to societal function by allowing parents and caregivers to return to work, including essential workers. Vaccinating all of those who are eligible around children is a much more effective intervention than isolating children. So we have a different measure for making sure that we support children to getting back to their important activities as soon as possible. With the increase in transmission in our communities, we've also seen increases in cases and outbreaks in long-term care and assisted living, both amongst residents and staff. And for family members, for people who work and operate in long-term care, and for our public health team, I know this is very concerning. And our focus continues to be to protect our elders and seniors, who we know, and we've seen the data, are more vulnerable to severe illness, but also to balance that with ensuring our seniors have the care and the support they need. And we know that that has changed. That balance is changing as we've had the high uptake of booster doses, both in staff and in residents in long-term care. And as we've seen much milder illness in many cases with Omicron. So there is changes that we're making in how we support long-term care homes and residents and staff in long-term care as we're going through this transition period as well. And we want to make sure that we're achieving this balance, recognizing that depending on vaccination and booster doses, that illness has changed, and we don't necessarily need all the same restrictions that we had in place with more severe strains of COVID-19. I have spoken many times over the last 2 years of how we're all in the same storm, but we are all in different boats, and it is challenging when change is happening very quickly and when it's hard to keep up with what that means. We're all connected, however, and our experiences are unique, but our challenges in getting through this pandemic together are the same. Getting through this pandemic is far more than public health orders. It's about all of us taking care of ourselves, our families, our communities, doing our part every day. And we know the things that are working. We know that there are changes, and we're adapting and adjusting to those changes. We're working hard to get through this surge. And I want to thank everybody in BC for their efforts. I know it has been more challenging than ever as things have changed over this last month. And we have more distance to go. We are hopefully at a place where we are getting through this wave again, and we'll be in a better place very soon. And we will see this through together. Thank you.
Much, Dr. Henry, and I wanted to give a few updates on the impact of sickness on our healthcare workers and the healthcare system. and on rapid tests. I did want to note that the charts presented by Dr. Henry today will be posted on the Vccdc website, on the government website, on social media. I encourage people when they are to refer to them, because you will see yourself, but also the ones you love, in these charts. And just as an example, I can see myself in these charts, and I'll just explain to you what vaccination means for me in the present context and people in my circumstances. I'm in my 50s and I have type 1 diabetes. And if you look at this chart, it tells you that compared to being, if I were unvaccinated, my risk of hospitalization is a staggering 8 times higher than my current circumstance, which is I've been triple vaxxed. I've received 3 vaccinations. And the booster dose, without the booster dose, my risk of hospitalization would be twice as high. And this is true for people in high-risk categories. And I want to make this point to everyone. We emphasized at every stage of our vaccination program this issue of risk. Older people got vaccinated before younger people. Those who are clinically vulnerable, such as myself in this case, got vaccinated somewhat before those who weren't. And that has been true in the booster dose campaign. That has been the emphasis of that campaign, such that of those eligible over 70, about 85% of people have now been vaccinated. Of those who are clinically vulnerable in groups 1 and 2, that's not me, but groups 1 and 2, they're about 85% vaccinated. But it does mean that in those categories, people who have been twice vaccinated, but there are tens of thousands of people still in BC who've been invited to be vaccinated, who are clinically vulnerable, who are over 70 or over 65 or over 60 with higher levels of risk, who have not yet booked their appointments. And I encourage you to do so today. You received your invitation, you haven't booked your appointments in those cases, and this chart, read this chart, and then book your vaccination today. And for whatever reason, if you're one of the people in the categories, and it's a smaller group, because 93% of those over 70 received their first dose and 91% have received their second dose. But if you're in that 7%, or if you're in that 9% who hasn't been vaccinated, get vaccinated today. And if you are looking for a first and second dose, in general, you should be able to do that through this weekend. So I suggest to everybody that they take this information about themselves, but also about the ones they love, and act accordingly, which is following public health guidance, following public health orders, protecting one another in what is a difficult time and a difficult storm, and protecting our healthcare workers and healthcare systems. I just wanted to update you with respect to rapid tests and where we are today and how that's changed in the last 3 days. At the end of day yesterday, BC had received 5,958,820 rapid tests to date, and deployed 3,860,064 of these tests to key strategic areas. Of the 5.9 million tests received, more than 1,099,000 were received over the last 4 days. That's since Monday, January 17th. That leaves a current inventory of 2,098,000 tests, including the million we just received. 558,000 of the current inventory are not suitable for deployment, for takeaway or personal use. They require special equipment, administration by trained healthcare professionals, etc. They can't be broken down. So those are going to be continued to be used by medical health officers to manage clusters and outbreaks. That leaves 1,539,820 tests that are suitable for self-administered use. This week we will be delivering and allocating those tests as follows: 150,000 to replenish supply at acute healthcare facilities for testing of symptomatic healthcare workers, 192,400 for repackaging and distribution to testing sites across BC to replenish their supply, and I received some questions about that yesterday. 115,000 more tests are being prepared to support testing in the K-12 education sector. This is a total to date of 345,000. 236,998 more tests for use by businesses and organizations as part of the point-of-care screening program. And long-term care and assisted living sites will continue to receive additional inventory to replenish their supply. The remainder and new supply arriving in the next few days will be allocated in the days ahead to long-term care, acute care hospitals for staff, testing sites, businesses, K-12, and post-secondary. And just to put it in context, because we hear a lot of talk about numbers all the time, that we expect to receive, and this is information from the federal government, between now and the middle of February, 15,719,920 tests. I wanted to also take the opportunity to update you on the impact of illness on healthcare workers and our healthcare system. I want to again express my thanks to healthcare workers, to our incredible teams of healthcare professionals in public health across the province who are working tirelessly day and night to get us through the pandemic. Health authorities have closely monitored sickness levels across health services, especially in hospitals, long-term care, and home support. So I want to bring you some up-to-date numbers, which show, I would say, an improving situation, but one that is still a significant challenge. From January 17th, the 3 days from January 17th through 19th, at least 7,952 workers called in sick. This includes 1,601 in Vancouver Coastal, 2,325 in Fraser Health, 1,919 in Interior Health, 1,947 in Island Health, 948 in Northern Health, 1,096 in the Provincial Health Services Authority, and 441 in Providence Healthcare. Just to be clear, this is not all COVID-19. Illness could be due to COVID-19 or something else. We continue to have mitigation plans in place to deliver the healthcare British Columbians need while also keeping our communities as safe and healthy as we can. Just to put it in context, and when I talk about an improving situation, if you look at the period from January 10th to 12th, which I reported at last Friday's regular briefing, there were 11,010 healthcare workers sick in that period from January 10th to 12th. The equivalent period, again, no statutory holidays involved here, January 17th to 19th, that number is 7,952, which is significantly less, about a quarter less, a little over a quarter less than it was, which is a significant reduction, although significantly above as well what is expected in normal times. I'm committed, we're committed to restoring all services that have been interrupted in the weeks to come. Just want to give you an update on some of those services so you know where we are. Since the announcements, the information bulletins, and the briefings from Health Authority CEOs on Tuesday, a number of changes have occurred. As you've seen from the daily information, critical care demand in Fraser Health has increased. In response to this, Fraser Health has operationalized an additional 10 critical care beds to ensure those patients needing the most care have access to it. Staff have been redeployed to support this, but there have been no further service reductions in Fraser Health. Next week, Island Health is resuming some non-urgent and ambulatory care at community hospitals in the region. And Invermere, which we reported on Tuesday, in Interior Health, inpatient services will remain open. Previously, there was a plan to stabilize those services to support the emergency department. So we continue to have these plans in place, and actions have been taken. And in the last week, there has been amazing work by healthcare workers in BC. We're doing close to 60,000 vaccinations a day, the vast majority of those being booster doses. We've done, since the beginning of the booster dose campaign, 1,750,000 booster doses, prioritized to those at the greatest risk for severe illness, which is, I think, an extraordinary achievement, and that is, of course, increasing significantly every day. We're deploying more rapid tests than ever before. Our healthcare workers are treating more patients in our hospitals. 9,400 was the patient census across acute care yesterday. In short, there is an enormous amount to be proud of in our healthcare system, and it's our absolute intention to restore all services as soon as possible, the services that we are delaying currently to support core services to our healthcare system. That will happen. And in the meantime, the best thing all of us can do is get vaccinated. Get your first shot, get your second shot, get your booster shot as soon as you're eligible. The vaccine remains our best defense. The evidence today shows that again, as every piece of evidence has shown it from the beginning of the pandemic. It saves lives every day, these vaccines. Earlier this week, I reported on non-urgent scheduled surgeries that have been postponed because of COVID. It's a significant number, and the postponements have a significant effect on all those whose surgeries aren't occurring as planned right now. To those patients and to their families and friends who provide them with comfort, care, and support, I would hope that as they go into this weekend, they know this, because this is also the reality of our patients, of our pandemic. Patients whose surgeries are postponed are never forgotten. Patients whose surgeries are postponed will receive a call to rebook their surgeries. Patients whose surgeries are postponed will get their surgeries. We made that commitment, and we will deliver on that commitment as we have done earlier in the pandemic. So as the rest of us go into the weekend, I would hope that all of us would understand just what surgery postponements mean to those patients and understand the ability we have to reduce their anxiety by exercising the control we have to stop COVID's rapid spread and reduce the negative impact it is having on our hospitals and providers. So let's make this another weekend where we all continue to do our part by doing the job so many are counting on us to do, put COVID in its place and slow its current surge. Have a safe weekend, everyone. We'll see you, of course, at the briefing in the coming week. And with that, I'm happy to take your questions, or we're happy to take your questions.
Reminder to everybody on the phone line, please press *1 to enter the queue. First question today is from Penny Daflos, CTV.
Thank you very much. Dr. Henry, I just wanted to start with you. What is your goal right now?
In terms of what? Obviously, we want to, our goals have not changed. Our goals are to reduce serious illness and deaths and morbidity and mortality from the pandemic. It's to preserve our health care system so everybody, whether it's from COVID or needs care for other reasons, are able to access the care they need. And thirdly, to minimize societal disruption so that we're minimizing those negative consequences of any of the measures that we're taking to manage the pandemic. That has not changed.
Penny, do you have a follow-up?
I do, because Dr. Henry, you keep talking about this being a transition period, but in a really short amount of time, you've slashed isolation guidelines, both in community and acute care. People who show up for testing now are being turned away even if they have symptoms because they're told they're not in a high-risk category or a healthcare worker. So it looks like you've more or less given up on trying to control COVID and completely switched to endemic mode over just a few days, even though our hospitals are still full and the staff are barely holding on. So I'd like to know how you've come to the decision to go to endemic mode now.
Yeah, so that is not correct. We are clearly not in a place where it's endemic right now. What we are doing is adjusting to the changes that we've seen from the new variant. It's what we're dealing with right now. And it tells us with the shorter incubation period, and I talked about this a number of times over this past month, this surprised us. It came out of places where there was still a lot of transmission of the virus, and this virus continues to be persistent, to be changing, and to cause different patterns of illness. And I talked about having to put together the pieces of the puzzle to understand how this virus strain was affecting us. And what we have seen is that the measures that we were using to help manage in other strains of the virus, particularly Delta, which was more infectious and more severe, but still had that longer incubation period. Some of those things that we were doing are no longer effective now, and that's the parameters of the virus have changed. So we need to adapt to it, which means we need to adapt how we take the approach that we have across the board. So because we have a shorter incubation period, because the vaccination is not 100% protective against infection, we needed to really look at, who is most at risk now, who is more likely to end up in hospital, how do we preserve our healthcare system, how do we reduce serious illness and deaths continuously. So it is adapting to the situation we're in. And we've had a number of different orders. We've gone back to our COVID safety plans. We've put in place some restrictions on gatherings. So this is clearly not where we want to be for when we're living with this virus in an endemic state. But I do believe that we will be moving towards that. And one of the things that has changed is the level of exposure that we've all had now to COVID because of this new strain and how it's moving through our communities. But I can't say enough how important the measures that we have in place. So we have these effective things now, like vaccination, and it is showing how important it is that vaccination does allow us to minimize those disruptions on society as we're continuing to have the restrictions in place that we need to get us through this place. And, you know, it's not my choice that this virus is causing more illness in healthcare workers. You know, it's a reality, and so we're talking about how do we manage with the reality that this virus is causing more illness and more people to be off work in healthcare, but in other sectors as well from illness. So it really is my job to raise that as this is one of the key things that we have to deal with in this phase of the pandemic. And we're not yet in an endemic state, and we have additional measures in place. But we all need to go back to the basics as well, because the things that we're doing to prevent us from getting infected and to prevent us from passing it on to others are incredibly important right now.
Next question is from Richard Sussman, Global News.
Dr. Henry, I know this will be jarring for a lot of people to hear the sort of shifts today, and I know you've been alluding to this for a while, but it's different than what we're seeing in other jurisdictions. And I know when you're asked jurisdictional questions, you say we're all dealing with this differently. But Dr. Tam is speaking about how symptoms can last for 10 days. We end isolation periods after 5 days. Other jurisdictions aren't going as far as saying close contacts don't have to isolate at all. So can you explain what science we are looking at here that makes our policies different than what we are seeing in other jurisdictions?
Yeah, so what Dr. Tam says, and I talked to that again today, but yes, symptoms can last for longer than 10 days, and symptoms can, people can transmit, but your risk of transmitting goes down after 5 to 6 days, and we have seen that with this strain. So yes, and what she was referring to is a study that showed that it was down to about 15% risk. And so what we are doing is with the reality that we have here, and this is something that we have discussed across the country with my colleagues in the Chief Medical Officers of Health. We've been meeting with the lab scientists, with the modelers, with others to try and understand how do we best manage this. And so what we're looking at here is what we're seeing, and I presented the data on people in hospital. We presented some of the data last week on who we're seeing getting sick and how long they're getting sick and what the incubation period is that we're seeing. So we're trying to mitigate that risk of causing more harm by healthcare workers not being in at work at a period of time when they're fully vaccinated and having mild illness that's not lasting very long. So we have to balance those things and deal with what we have here. And I will say that there is consistency across most of what we're doing across the country. And yes, some people are taking and it depends a little bit on what they're seeing, as I've said, where they're seeing outbreaks happen, where they're seeing more severe illness happen. And we're dealing with slightly different proportions of Omicron versus Delta and people who are hospitalized and in outbreaks. So it is a bit varied. I look at my colleagues in Prince Edward Island, a place that's my home, and you know, this is the first wave that they've been through. So there is a much higher level of concern about how to manage it. We have been through this. We have things in place. We have COVID safety plans in place that they don't have necessarily in other settings.
Richard, do you have a follow-up?
Dr. Henry, you mentioned long-term care there as well. I think a lot with loved ones in the facility are hoping for and waiting for new updated guidelines around visitation. You know, when should we expect to see those new guidelines around long-term care? And just briefly, can you speak to me about what happened at the Vccdc this week and why on Tuesday they updated guidelines saying unvaccinated people could only have to isolate for 5 days, then on Wednesday it went back to 10 days?
Yeah, these were ongoing discussions that we were having. I just mentioned this in my last discussion. These are moving targets as we're learning more, and it was a misunderstanding. And when I recognized that was posted, and we changed it. I think our challenge was we changed it without letting people know that it was a mistake in the posting in the first place. These are things that are changing really rapidly, and to be frank, my staff are tired. We've been working on this for a long time, and we are also being affected by the fact that lots of people are off sick right now. So it was an administrative challenge and an error on our part that we corrected as soon as we did, and it's my responsibility to communicate that better, and I'll do that in the future.
Next question is from Cole Schisler, Black Press.
Hi there. Dr. Bonnie Henry, at your last press conference, you said there's a narrative that Omicron is mild and cautioned that 1 in 10 people have symptoms for 12 weeks or longer. But you've said numerous times, even today, that Omicron is milder for most people. So is it a narrative or is it a scientific fact? And do you take any responsibility for that narrative given your past statements and policy changes based on Omicron being milder?
Yeah, so I think I have tried to expunge the word mild from my lexicon because it means different things to different people. So I was trying to make the point, and there is a narrative that I don't believe I've tried not to contribute to, that we should just abandon all restrictions. We should not be doing anything. We should just let it go because it's mild and who cares? And so I do not subscribe to that narrative. And I think it's important to recognize, and we showed that again today, that there are some people who are at higher risk, and we all have a responsibility to try and minimize our risk to them by doing the things that help protect us and protect others. So it really, I guess, I'm trying to find that balance of saying, yes, it is not causing as much severe illness, particularly in people who are vaccinated. So that's the really important thing. And a lot of people who, particularly if you've had your third dose, younger people are not having severe enough illness to end up in hospital, but it is not an innocuous illness. It is making people feel very unwell, some of them for a longer period of time. So I'm trying to find the balance between that.
Over to you, Minister Dix.
Just to say this, that Dr. Henry said today what the facts are, which is that in an individual case, Omicron has been less severe, but there are significantly more individual cases, which presents very significant problems for lots of people. And that's why, since the Omicron variant of concern came on the scene, there were public health orders on January 20th, on the 23rd, on the 29th, on the 31st, another last week with respect to COVID safety plans for businesses, public health orders in place in all those respects to respond to this. And we have seen, and we are seeing, some decline in test positivity, although it is still extremely high. So those are the actions taken. In addition, we are doing, at a time when there's a lot of pressure on the healthcare system that everyone acknowledges, a massive number of vaccinations every week in booster dose vaccinations, such that 85% of people in the most vulnerable category, people over 70 who are eligible, have got their third doses, their booster doses. Earlier, before that, we'd prioritize people who are clinically vulnerable. On December 21st, we put in place our rapid test plan, our new rapid test plan, which follows on the one from March of 2021. In that period, we've been providing more care and preparing our hospital system for the impact of Omicron on healthcare workers. And those steps have been taken, were prepared and announced before Christmas, especially with respect to non-urgent scheduled surgeries. And our healthcare teams are putting them in place so we can continue to provide the extraordinary service, including yesterday, 9,400 people in acute care. So there has been, these are actions that have been, I think, allowed people to see in those actions what they need to do, and that's been happening as well. that Dr. Henry and her team have led, and the Ministry of Health, myself and others have led as well. And that reflects, I think, their extraordinary commitment and the commitment of people. And I have to say that when I travel around BC, when I go to the grocery store, as I did yesterday evening, everyone is wearing their mask. I have not seen someone in a grocery store in months without a mask on. And that shows the effect of the public health order that was put in place by Dr. Henry. So I think that what we try and do, and what Dr. Henry has done with more detailed information here about the risk of hospitalization, has been followed through on specific actions in every area to help people deal with a real public health challenge that is more severe in other parts of Canada, the Omicron variant of concern, but is really had a similar effect on countries around the world. And I'm very, very proud of our public health teams and Dr. Henry's leadership, and I think British Columbians are as well.
Cole, do you have a follow-up?
Yeah, this might be a better question for Minister Dix. But there were reports that a new policy from Fraser Health says patients who are positive with COVID may be able to share rooms with fully vaccinated patients who do not have COVID. Can you explain the rationale behind that decision, and are similar policies on the way for other health authorities across BC?
Is about maximizing our ability to provide care to people. So as we have presented, and again today, but primarily last week, we've been looking at how many people are admitted to hospital where their test on admission is positive. So it's an incidental finding. It's not the reason for being in hospital, and they don't have respiratory illness related to COVID. And in those cases, being able to maximize the use of space if needed, with additional precautions in place, as we would for people admitted with other respiratory illnesses. So that is an infection prevention and control team decision made at a hospital by hospital, and actually room by room and ward by ward basis, depending on the needs in that facility.
Oh, over to you, Minister.
Dr. Henry made this point. Last week, as did I, that the challenge of having more people in a hospital is the challenge of cohorting everybody is much more difficult. And so that's why we have on-site infection control teams taking charge of the situation. We had yesterday 891 people, according to the information we provided in the update yesterday, 891 hospitalized positive for COVID-19 yesterday in that announcement, our hospitalization announcement. The record, the pre-Omicron record, was in the 500s. There were more than 500 people in hospital in the Fraser Health Authority, and so they are managing that, led by infection control teams, and doing a good job. And it's a real challenge, though, and it has affected healthcare systems as well. There's obviously, for example, as I say, 2,325 employees with sick hours in Fraser Health from January 17th to 19th, which is not an insignificant number, more than we would usually see by probably a quarter, 25%. So that's a significant thing to manage. But our infection control staff are doing a good job. But when you have a lot of people in the hospital, you have to manage within the space you have and ensure that infection control stays high. And that's what our teams are doing in hospitals across BC.
Lisa, you.
Hi there. I'm wondering, and I think probably it's you, Dr. Henry, maybe Minister Dix, regarding the testing. So the basics are, if you are vaccinated and not in one of the high-risk groups or working with a high-risk group and you're over 18, you pretty much cannot get a test if your employer doesn't provide it or if you're not part of some sort of outbreak response. Is that accurate, that pretty much your only routes are through work or through some private measures if you are over 18 and vaccinated and not one of the high-risk groups?
And you have mild illness, yes. So it's a finite capacity for testing, and we need to reserve that for people where it will change their management or their ability to go to work, for example. So that's the best use of testing right now. And I think that's one of the reasons why, there are many people who have illness, with mild illness right now, some of which is COVID. And we all just need to take those measures to stay away from others and not pass it on to others if we're feeling unwell.
Lisa, do you have a follow-up?
What is going to happen for people who have with long COVID? There's many people concerned that if they don't have this positive test, they're not going to have access to that treatment. And then I guess sort of it goes a little bit to if people ever need to leave the country and they've tested positive, they're not going to test going out, which I know is, less a priority. But what does this mean for people who may need a positive test for other steps, particularly long COVID treatment down the road?
Yeah, so we are working with the clinics that we have around long COVID, and there are other ways of determining if somebody has been infected post hoc. So we can do antibody testing. It's not widely available, but it is a way of determining if somebody has had an infection with COVID-19. So that's not a prerequisite to getting treatment for ongoing symptoms that may be related to COVID at all. So I would not be concerned about that. And we are, of course, we are seeing that there's less risk. And of course, we're still collecting data on that. But if you're vaccinated and have milder illness, the risk of developing long COVID goes down quite dramatically as well. In the Delta wave, we saw that 2 doses of vaccine reduced the risk of long COVID if you did get infected by over 50%. And we have no reason to think it would be any less than that with Omicron. So these are the factors that we need to think about. In terms of travel, many countries are getting rid of that window that they are allowing people to say, I had a recent infection and I prove it with a PCR test. Those are optional things for people, and there are private ways that they can get a PCR test if it's required for travel, but it's not part of the publicly funded system.
Next question is from Lisa Cordasco, Vancouver Sun.
Thank you. Good morning. What direction or guidance is being given to long-term care homes about visits when they run out of rapid tests for those essential visitors?
Yeah, so as we mentioned, and I don't think I answered that directly, but we are updating the guidelines and working with the sector. But really, it's a triaging. So yes, if they run out of rapid tests, those regular visitors who were tested the day before can be allowed in with a symptom screening. So we will not be denying people those important visits because of a lack of access of rapid tests. We'll do the symptom screening, making sure that we have that people are prioritized, and making sure that we can use the rapid test for the people that we have more who are newer visits. And if there's none at all, then going back to what we have been using all along, which is the screening for symptoms.
Follow up, Lisa?
Yes, thank you. What is the plan for allocating more rapid tests to long-term care homes beyond the original 200,000 that was announced and we were told were already deployed? Is there a plan to allocate, what are the numbers for allocating any rapid tests in the future to long-term care homes? And also, as I understand it, there are no actual specific allocations to assisted living sites at the moment.
Yeah, so both of those are being addressed, and I'll turn it over to Minister Dix.
Minister?
We're receiving between now and the middle of February 15 million rapid tests. Rapid tests are being allocated to long-term care homes around BC. There's no real area of life or health that has a higher priority for us. The testing sites and acute care are equivalent priorities than long-term care, but I would expect long-term care homes to receive the rapid tests they need to support visitations and to support keeping their workers safe and keeping their residents safe. The challenge in long-term care, and you see it from the numbers on hospitalizations, is in general the people who are in long-term care are either over 80 or at least over 70 and have 3 or more conditions. So if you look at the chart, you see that the risk is very high for all those in long-term care, and is why measures have been in place and continue to be put in place to keep people safe, including that everyone requires double vaccination to visit. It requires rapid testing, and those rapid tests will be available. It requires infection control supports that have been put in place. Thousands of people have been hired to support those efforts. So it's really challenging right now because the Omicron variant of concern is everywhere, as we've seen in BC with these very high case counts, and that includes people who work in long-term care and others who are essential visitors. So we're going to continue to take strong action to protect long-term care.
There are many where there's co-location of assisted living and the campus of care and long-term care, and rapid tests are available for those settings. And we, as more shipments come in, assisted living will have access as well.
Next question is from Victor Kaiser, Radio NL.
Good morning, Dr. Henry and Minister Dix. I'm going to shift this a little bit. I've been following the story, of course, about service reductions in interior health. I guess the question's for the minister because of these Omicron staffing challenges, most notably in Barrier, but also Ashcroft, Clearwater, and other places like Kamloops. Local mayors tell me they were not told about the changes, Minister. And, despite being in meetings with interior health, that morning, right, when things were announced, they found out about it in a press release. In your mind, is that acceptable? And I guess also, is it acceptable for us to close an entire healthcare facility like Barrier and redirect people to RIH, which you've said yourself has been in crisis for weeks and months?
To understand what happened, Interior Health presented its plan, its surge plan, on paper at the time of the briefing. There was a meeting with Interior Health mayors that everyone was invited to at 3 o'clock, I believe, that day. And a briefing was given by Susan Brown, the President and CEO of Interior Health. I was on the call, and Dr. Henry was on the call. And as you know, because you cover these issues, there's been challenges throughout the last month in Clearwater and Ashcroft, and the idea was to support the emergency department by reducing inpatient services to maintain stability of care for urgent and emergent care, and that's what they're doing. And our plan and our intention is to restore that care, but we should acknowledge the very high test positivity in Interior Health and the real healthcare challenges there. The difference in some ways between Interior Health and the Metro Vancouver Health Authority is that even though there are, of course, many, many more people in Metro Vancouver, that the facilities are physically closer together and there's a greater ability to support them. That's been a challenge in smaller towns. But as we're only going to do this if we need to do it to protect and support patient care. In Invermere, for example, the plan had been to do just that, and it's been decided by Interior Health they don't need to do that. And as the number of healthcare workers off sick has actually reduced this week, including in Interior Health against last week, that situation will get better. But these are plans put in place because of the necessities of the Omicron variant of concern. It's Interior Health acting proactively, and they have done, to protect the healthcare system there. It's a very significant challenge in Interior Health, probably greater right now than any of the other health authorities, and I think our teams are doing a good job. But no one wants to see any service, even temporarily closed, and that's why it's our intention and our ask is for everyone to follow public health guidance and orders, and that we need to take these steps to support the system and support care in the system, and that's what they're doing. So I think, I don't know with respect to the complaints. I'm happy to talk to the mayors, but I can tell you that the information bulletin went out, I believe, at 3 o'clock. The briefing happened at 3 o'clock. The press conference happened, I believe, at 1:30. And so, questions, and we answered questions from mayors across Interior Health between 3 and 4. And Susan Brown, who's our CEO in Interior Health, has been working day and night to support communities and support services in Kamloops and everywhere else. With respect to Barrier, it is unfortunate, but the intention is to ensure that we bring our staff together to provide the care that's necessary. And it's our hope to reopen there as soon as possible.
Minister, do you have a follow-up?
I guess go back to some of the changes, I guess, in policies and testing and what have you. The message has been stay home if you're sick, right? I mean, that's I guess all fine and what have you. But what would people do if they only have those 5 paid sick days, brought in by the government? Because I know of a couple who've told me they've used 3 or 4 such days. Here we are now on January 21st. And, they've got most of the year still to go, and they're worried that they're either going to be forced back to work when they need to stay home, or if they choose to stay home, they're not getting paid, and then we know they have trouble perhaps making rent and what have you. So what do people in that boat do when they don't have those paid sick days and they're running out?
I think I'll defer to the minister around that.
Go ahead, Minister.
Well, Victor, you make the point that we do, as of January 1st, have 5 paid sick days in BC, which is 5 more than other Canadian provincial jurisdictions, and that's important. And that doesn't mean it's easy or that when people get sick, they don't face real challenges, but it's important that we have those sick days in place now. I think people in BC overwhelmingly support them. They support public health efforts to manage the COVID-19 pandemic. And yes, it's a significant challenge in many sectors. Obviously, people have largely in unionized sectors, and others people have a higher level of sick day protection. But 5 days is a significant improvement, but this recognizes, everybody recognizes the challenges workers face, not just now, not just in the COVID-19 pandemic, but in general, in dealing with sickness. It's why it's also so important that we keep public services open, and why the fact that BC has kept schools open has been so helpful to families and to children throughout this pandemic period, and that hasn't been the case everywhere else. So I recognize the challenge. I empathize with that. That's why we put our province-wide sick day plan into place, and this illustrates the importance of that plan. And you may be making the case that there should be more days. And I hear that concern that's been expressed by many as well. But 5 days is an excellent start in protecting workers.
We have time for one.
Good morning, and answers, please, both in English and French. The West Vancouver School District wants vaccine clinics for children to be set up in schools. Will you consider that in that district and other districts, given the relatively low rate of vaccination in children 5 to 11 in BC?
Absolutely, and I know Vancouver Coastal is working with each of the school districts, every school, as are the health authorities around the province. And in some areas, some schools in particular, it has been done and it will be done again. But those are decisions made on a school-by-school basis with the local MHO.
Go ahead, Minister.
Oui, je dirais en français que ce sont des décisions faites en consultation avec la Régie de santé et le conseil scolaire. Cela étant, il faut forcer de reconnaître qu'on n'a pas beaucoup réussi avec des cliniques dans les écoles pendant juin et puis septembre et octobre. C'était une difficulté. On avait beaucoup plus de réussite sur le terrain pour les cliniques en général. Et donc, on voit cela dans les résultats pour ceux qui sont entre 5 et 11 ans maintenant. Il y a des différences. Dans Vancouver Coastal, il y a à peu près 64-65% des enfants qui ont reçu leur première dose de 5 à 11 ans. Et dans les autres régies de santé, c'est beaucoup moins, en fait, en général, surtout dans le Nord. Donc, il faut continuer à y travailler. I just say the numbers are pretty straightforward, Bell. We're approaching 50% of all children 5 to 11 who have received their first dose vaccination. Some will be receiving their second dose fairly soon, in fact. And there's very significant variations. Vancouver Coastal Health, which is the health authority that West Vancouver is in, has a relatively high rate of immunization. I think it's around 65%. The Northern Health Authority for children 5 to 11 is much lower, 30%. In fact, there's very little difference between the health authorities in the 70 and above category, and pretty wide differences between 5 and 11. What you'll also see is that every year, if you go from 17 to 12, this is true, and from 11 to 5, that each younger cohort has a lower level of immunization than the one before it. So we're going to take all steps to try and increase immunization across the system. But as Dr. Henry said, and we have a lot of experience with this, with those 12 to 17 now, the most effective clinics for us with children 5 to 11 and 12 to 17 have been community clinics so far. And often when we've gone into schools, it's led to a somewhat slow response, but also has brought challenges to some of those schools. So we're, and not fantastic results in terms of immunization, but we're learning every day, and there's going to be cases where there's schools, and certainly that's true in places in remote and rural areas of BC, excuse me, remote and rural areas of BC, where we're doing olive community approaches, and those olive community approaches tend to take place in the schools.
Belle, do you have a follow-up?
It's like you're preparing British Columbians for the long haul, how we're going to live with COVID-19 for the long term. That's pretty bleak news for those who are clinically extremely vulnerable. What's your message to those people today? And English and French, please.
Yeah, so I do think, I don't think that this is how we're going to live with it in the long term, but it is what we need to do to get us through this part. And it tells us a couple of things. One is the importance of vaccination. We've seen that this booster dose makes a tremendous difference, even for those who are clinically extremely vulnerable and people who are older age. And, we maintained that interval, that 6-month interval, because we have ongoing evidence and increasing evidence that gives us longer lasting protection. So that is going to help for whatever comes next, because there will be something next. I do believe we're going to be living with this virus. What I hope and what I've talked about before is, historically what we see is sort of smaller and smaller oscillations. But it is a reality that people who don't have a strong immune system will still be at risk of having some more severe illness. And we see that with other respiratory viruses that cause infections as well, influenza being classic. And it is people who are older, people who have immune compromising conditions, and the very young who tend to be most at risk. And I expect that is likely to continue for some time. I hope, but hope is not a strategy, but I do hope that we will end up with another coronavirus that causes mostly mild illness. But it may be that people who are in that older age group or people who have immune compromising conditions will need to get periodic boosters. And it may be that most of us who've now had the 3 doses won't need to have periodic boosters. So those are the things that we don't yet know, but those are possibilities that we need to start thinking about now. And it has been trying to balance the best protection that we can get for the longer term and dealing with what we're dealing with right now that has led to the decisions that we've made around many of the things that are happening right now. So in that sense, you are right that we're preparing for how do we live with this when we no longer need to have those restrictions that we have in place now. And I do think we will get through this wave, and because of the amount of transmission we've seen and the amount of immunity that we've developed from vaccination and from the transmission of Omicron, that we're probably going to have a much more gentle summer than we've had for the last 2 summers. So that will be good. And then we'll have to prepare ourselves to whatever comes next in the fall.
Over to you, Minister.
All right, you were just listening in there on BC's latest COVID-19 briefing. We bring in now our Legislative Bureau Chief, Keith Baldry, who joins us from Victoria with some analysis. Now, Keith, something that stood out right away is that the province is no longer relying on contact tracing to prevent transmission, that we should all assume we've really come into contact with someone who has it. Can you expand on what Dr. Henry said about living with it and going back to basic principles?
Yeah, so we relied heavily on contact tracing when we were only picking up 400, 500, 700 cases a day because we had 1,500 contact tracers, I think, at the peak. So they were able to stay on top of the cases for the most part, by and large. But now that we're having 2,000, 3,000, in some cases, 4,000 cases detected a day, it just basically overwhelms the contact tracing system and its strategic use. So the assumption is now Omicron is so much more infectious, it's hitting so many more people, that the assumption is you probably know someone or you've been in contact with someone who's had the virus. So finding the virus right now is not as critical a task as is ensuring the people most vulnerable of the most severe outcomes of getting the virus are protected. And that means ensuring that as many people vaccinated as possible, particularly older people. And again, that's the number one layer of protection is vaccination. The charts she provided today shows that by and large, unvaccinated people in particular over the age of 70 run a real risk of going into hospital and potentially the ICU. And the percentages just speak, again, it's all about age. People over the age of 70 are really the highest risk of going into hospital. And the risk of really severe illness is really not there for younger people who are vaccinated. So the use of contact tracing back when we didn't have a lot of people vaccinated was sort of greater than it is now to pick up whether or not the virus was in a 40-year-old, for example, or a 30-year-old. That's not as critically important now as it is ensuring that people who are most vulnerable don't go into hospital.
Now, Keith, a huge focus, as you said, on hospitals today. Looking at the bigger picture, how are our hospitals faring given the recent increase in COVID cases?
Yeah, it's very interesting. So the hospitalization rate is actually lower, and it takes a while to figure this one out, than the fall. But in the fall, we didn't have as many positive cases. So the percentage of people in hospital was actually higher compared to all the positive cases than it is now. When we've got so much more positive cases, even though the number of people in hospital right now is greater than the fall, the percentage of positive cases is actually lower. So on the one hand, it's putting people in hospital in greater numbers, but it's not causing a bed shortage as of yet, Emily. But what it is a concern, and I think one of the questions addressed this, is and Adrian Dix provided an update on how many healthcare workers are sick right now. The number is dropping, which is encouraging, but it's still almost double what it usually is. And that has a big impact on the providing care in a hospital that now, yesterday, for example, I think 158 people went into hospital, 162 people came out. But there still means a lot of activity in terms of testing people in hospital. So it hasn't overwhelmed the system, but it's certainly creating pressure like we have not seen before.
I wanted to touch on something, again, related to hospitals. We learned of new information that Fraser Health may no longer be able to separate those who are COVID positive from other patients who don't have the virus but are fully vaccinated. So what is exactly the reason for this?
Basically a crunch of space and people. So many more people are going into Royal Columbian and Surrey Memorial right now. About half the cases every day are in Fraser Health, half the hospitalizations. So when we're having more than 100 hospitalizations a day, that's 50 or so people that are being hospitalized in some of these large hospitals in Fraser Health. And so the number of people going in is significant, and literally anybody who's been into Royal Columbian or one of these hospitals knows there's only so much space in wards. It was easier to separate people when we had fewer patients in there. But yesterday, 891 patients with COVID. Our previous peak was back in April at 500, end of April, April 28th, 515 people. So we're almost doubling that in terms of size. So literally running out of physical space in the Fraser Health hospitals, and that's why, it's not across the board. Not everyone is going in, not all positive cases are going to be with all negative cases. If people have respiratory ailments, they are still going to be separated. You can still have different forms of Omicron and different symptoms, so it's not a uniform system, but it does mean in some cases people who test positive with Omicron will be in the same ward as people who test negative. It's just, again, it comes down to physical space or lack of.
Just want to switch gears a bit here. You have some new stats, I understand, Keith, the vaccine rates among kids, and it does seem some regions in particular are struggling to get their numbers up.
Yeah, this came up at the very end of the briefing today. So the vaccination rate for 5 to 11-year-olds has really been a bit of a grind. It's proceeding nowhere near as quick as we saw with older groups. So right now, the province-wide average is 48% of the 350,000 kids in that age group have got their first dose. But as you mentioned, Emily, it does vary from region to region. It's a high of 63% in Vancouver Coastal, which again had the highest vaccination rate amongst adults in terms of outpacing other regions.